Thank you very much. It is a tremendous honor to be here with all of you, to be able to speak with all of you. I've lectured all around the world at many places, and I must say none has compared to this in terms of how friendly the people are at the meeting and the level of hospitality. So I thank you very much. I want to thank the organizers for allowing me to come and spend a short time with you. Now we're going to talk today about the important parts of the body, that is the chest and abdomen. It's not that the brain is not important, it's very important, but not nearly as important as this. Without the brain, of course, we could not think, we could not do our jobs as radiologists, and without the brain, we would all vote for Donald Trump. So we want to acknowledge that. But this is the real interesting part of the body. So we'll talk first about pancreatic neoplasms. And you can see there's a long list of, long list of pancreatic neoplasms out there, both solid and cystic. This is just a list of solid neoplasms, and you can see it's a very long list. And it's really too much to cover, and most of these are very rare, so we don't want to spend that much time on things you may never see. So what I would like to do is focus on the common neoplasms, and those are the ductal adenocarcinomas, neuroendocrine tumors, and the cystic neoplasms listed here. We'll start with ductal adenocarcinoma. This is a malignant neoplasm of ductal epithelium. It's a common disease. In the United States, there's about 40,000 new cases and 40,000 deaths per year. So this is a major health problem. And only about 20% or less of these patients are candidates for curative resection. So most of these patients present in an advanced stage that's not curable. The 5-year survival is very poor, as we all know. It may only be as low as 5%, although I think that is improving with new techniques. And if the tumor is resectable, you still have a relatively poor survival of only up to 27%. The risk factors are listed here. Many of these are things that are preventable, such as smoking, obesity, but some are things we can do nothing about. For example, family history or genetic syndromes, which make up less than 10% of the causes. The precursor lesions are pancreatic intraepithelial neoplasia, the intraductal papillary mucinous neoplasm, which we will talk about later, and mucinous cystic neoplasms. And about 10% have coexisting pancreatitis, which makes the diagnosis very difficult because it's hard to tell what's tumor and what is pancreatitis, or the pancreatitis may mask the tumor, which is the cause of the pancreatitis. So this creates a lot of confusion for us diagnostically. About 60% of pancreatic cancers are in the head of the pancreas, which is unfortunate because that's really the important part where the bile duct and the pancreatic duct pass through. So let's talk first about the findings of pancreatic cancer on CT and MRI. The most direct sign, of course, is that we see a pancreatic mass. Now, sometimes this is very difficult to see, particularly if it's a small mass, but even large masses can be hard to see. And this is a very difficult